Hello doctors. In this video we will study about infective endocarditis. It is an important LAQ for university exams. So let's get started. Infective endocarditis is a microbiological infection of heart valves and endocardium. So mainly there will be bacterial causes. So major etiology will be bacteria, and then some fungi will also cause infective endocarditis. There will be vegetation formation around the valves of the heart. Etiology will be there is highly virulent organism, low virulent organism. High virulent organism is Staphylococcus aureus. It is a commensal on skin. Commensal organism means it naturally resides over skin. Commensal on skin. Low virulent organism is Streptococci viridans. Streptococcus viridans is low virulent organism and it is a commensal in oral cavity. So there will be coagulase negative staphylococci. Example Staphylococcus epidermidis. It is the major cause for prosthetic valve endocarditis. Major cause for prosthetic valve endocarditis. And as a group of organisms are fastidious, slow growing, gram negative bacteria. So what are the organisms? Let's see. So H is Haemophilus. A is Actinobacillus. And C is Cardiobacterium. E for Echinella. And lastly K for Kingella. So these are the as a group of organisms. Are fastidious, slow growing, gram negative bacteria. So other organism which causes infective endocarditis are Enterococci species. And there is a specific type called culture negative endocarditis. It includes 10 to 15% of infective endocarditis cases. It means there is no organism in culture. No organism in the culture. So when you search for reason, it will be the patient will be on prior antibiotic therapy. and there may be causes for difficulties in isolating the organism. So this is about culture negative endocarditis. So this is all about etiology. So let's see. So highly virulent organism and low virulent organism. So coagulase negative staphylococci. Example is the Staphylococcus epidermidis. Next has a group of organisms and Enterococci species. So this is about etiology of infective endocarditis. So if you want, you can take a screenshot. So now let's go into pathogenesis. So first we will discuss it from risk factors to clinical features. So I have made this diagram so that it will be easy. So first, risk factors. Risk factors are underlying heart diseases and iatrogenic. So heart diseases like valvular heart diseases. So example, rheumatic heart disease and congenital heart diseases. And iatrogenic causes there is trauma and prosthetic valve. So these are the risk factors which will cause endocardial damage and denudation of endocardium. So it will cause inflammation. So endothelial damage will cause inflammation and there will be formation of sterile thrombus on valve leaflet. So in this, you see here, this is the valve leaflet. These are chorda tendinae. There is formation of sterile thrombi on the valve leaflet, and microorganisms in the bloodstream will adhere to this sterile thrombi. So microorganisms adhere to sterile thrombi and they will form the vegetation. They will proliferate and they will form vegetations. So proliferation of microorganisms within the vegetations. So here see my bacteria in bloodstream are lodging on this my sterile thrombi and they are proliferating within the valve leaflet, and there is, you can see, there is provocation of inflammatory response. So these are leukocytes, you can see, so it indicates inflammatory response. So complications will be embolization and murmurs, valve regurgitation, heart failure. So clinical features we will see further. So on prolong of the disease, there will be healing due to fibrosis, healing by fibrosis, and there will be calcification also. And so here you can observe that the chorda tendina are thickened. So if you think about why there is formation of sterile thrombi, why there is formation of sterile thrombi, you will get to know that. If you think about why there is a formation of sterile thrombi, so it is due to interaction between endothelial damage and hypercoagulability. So why there is hypercoagulable state means the conditions like SLE, systemic lupus erythematosus, and sepsis will cause hypercoagulable state when there is endothelial damage. So there will be inflammation. So inflammation will trigger repair mechanisms like coagulation process, like coagulation. So individuals with this SLE and sepsis, so where there is hypercoagulability state, in that individuals there will be high amount of platelets and fibrin are deposited. Platelets and fibrin are deposited on valves. So as these high amount of deposition are devoid of organisms, so it is sterile. So this is the detailed info about why there is formation of sterile thrombi on valve leaflets. So again, if you think about why there is entry of organisms into blood vessels. So here you can see adherence of microorganisms on the sterile thrombi. So if you think about where do these organisms come from into the circulation, then you will get to know that it is due to the conditions like some dental procedures, cardiac procedures, genitourinary procedures, and skin, wound, lung, genitourinary infections, indwelling catheters, injections, drug abuse. So this all will lead to, they all will open a portal for the organisms into the bloodstream. So their organisms will gain access into the bloodstream and cause further pathogenesis. So this is pathogenesis of infective endocarditis. So now let's go into morphology. So in morphology there are gross features and microscopic features. So first we will say about gross features. So this is a valve and these are chorda tendinae. So here you can see these are vegetations on the valve. This whole thing, these all are vegetations on the valves. So filled of fibrin, platelets, microorganisms. And these vegetations are vegetations. These are friable, bulky, and they contain fibrin, inflammatory cells, and bacteria. So vegetations are friable, bulky, they contain fibrin, inflammatory cells, and bacteria. So this is the morphology of the vegetations. And vegetation sometimes they will erode into the myocardium and cause ring abscess. So here you can see from endocardium they will erode into the myocardium. So endocardium to myocardium. So they will gain access into myocardium and there they will cause ring abscess formation. So you can collect this tissue for culture also. And we will see about microscopy. So on microscopy we will be able to see granulation tissue at the base of vegetations. Granulation tissue at the base of vegetations. So it indicates, granulation tissue indicates healing response. we can see fibrosis also, because there is inflammation, so there should be healing. So healing means by fibrosis and calcification, and there will be chronic inflammatory infiltrate. Chronic inflammatory infiltrate. So this is about microscopy. So morphology gross. Clinical features here will be fever, chills, weakness, and non-specific fatigue. Weight loss and flu-like syndrome. Flu-like syndrome. In older adults, there will be only manifestation of these symptoms without manifesting them. And murmurs are also present. Murmurs present in majority with left-sided infective endocarditis. So now we will see about characteristic lesions of infective endocarditis. So there are Janeway lesions. Janeway lesions, they occur on palms and soles. These are hemorrhagic, non-tender, hemorrhagic, non-tender lesions. Janeway lesions are small, non-tender. So next lesions will be ossular nodes. Ossular nodes. These are small, painful, and tender in consistency. They occur on pulp of digits. And at last, Roth spots. Roth spots are oval, pale, with pale centers. They are oval and they have pale centers. So these are ocular manifestation actually. So they are retinal hemorrhage. Retinal hemorrhage in eye. So ocular manifestation. So there are splinter hemorrhages also. Splinter hemorrhages due to microthromboemboli. Microthromboemboli. So these are important features of infective endocarditis. Janeway lesions, ossular nodes, and Roth spots. So these are clinical features of infective endocarditis. Now we will see about complications. Complications are cardiac and extracardiac. So cardiac and extracardiac. Cardiac complications are sepsis, arrhythmias, and systemic embolization. Systemic embolization. And non-cardiac complications are glomerulonephritis, So it is due to deposition of antigen antibody immune complexes. So clinical features will manifest within first few weeks. Complications will manifest within first few weeks. So infective endocarditis is fatal if left untreated. So this is about clinical features and complications. Cardiac and non-cardiac causes, complications. So this is about clinical features and complications. So let's jump into diagnostic criteria, which is last one. So we use modified Duke's criteria to diagnose infective endocarditis. So there are actually major and minor criteria in clinical criteria. So they come under clinical criteria. And there is pathologic criteria. So first we will say about pathologic criteria, then we will go for clinical criteria. In pathologic criteria, so there should be microorganisms in culture. So what will we use for culture? Vegetation and abscess, intracardiac abscess. So there should be microorganisms in the culture. And second one will be histologic confirmation of causative organism. So now we will see about clinical criteria. In clinical criteria, as I have told, major and minor criteria. Major have 3 criteria and minor have 5 criteria. So first we will see major criteria. So first one is blood culture should be positive for causative organism. Second one is echocardiographic identification. And third will be valvular regurgitation. New valvular regurgitation. So this is major criteria, and now we will see minor criteria. First one is predisposing heart lesion. Or IV drug usage, drug abuse or usage. Second will be fever. Third will be vascular lesions. So in vascular lesions there are major arterial thrombus and emboli, septic pulmonary infarct, mycotic aneurysm, and intracranial and conjunctival hemorrhages. And Janeway lesions. These are vascular lesions. So under vascular lesions, major arterial emboli, septic pulmonary infarct, mycotic aneurysm, hemorrhage and Janeway lesions are there. So fourth one will be immunological phenomena. And further in this there are manifestations like glomerulonephritis, Osler nodes, Roth spots and rheumatoid factor. So these are immunological phenomena. And at last, fifth one is microbiological evidence. At least one organism should be positive on culture. So these are criteria of modified Duke's criteria. So clinical and pathological. And how we will use this Duke's criteria in diagnosis of infective endocarditis, we will see now. So we will see first possible infective endocarditis diagnosis. So there may be chance of infective endocarditis. So for possible infective endocarditis diagnosis, the criteria should be one major plus one minor. So from clinical criteria, so there should be positive for one major and one minor, or also there should be three minor positive. So either one major plus one minor positive or three minor manifestations are seen, that means positive. This is for possible infective endocarditis diagnosis. For definitive diagnosis of infective endocarditis, there should be two major or one major plus three minor, or five minor. So there should be manifestations positive for two major, one major plus three minor, or five minor. So anyone which is positive, we can diagnose it as definitely it is infective endocarditis. So this whole thing is about diagnostic criteria, which is important part of this LAQ. And so thank you.